Sorry, yeah, Mike introduced there. I'm a GP down in Devon. I'm also one of the urgent care leads for Devon, NHS Devon, New Devon, CCG, or whatever we're called now. And basically, I'm just going to talk about how we integrated both predictive modelling and then the case management approach into a sort of a whole system picture, with the emphasis around virtual wards and where we've got to after the last 4 years we've been at. And so about urgent care, the best way I've ever sort of came to think about it is our old strategy is try and keep people at home, care closer to home, the best bed is my bed type approach. And the best way of describing it really is sort of in a pinball approach. So we're trying to use the levers to keep as many people at the top as possible rather than come down to the acute sort of at the bottom there. That's the basic structure of where we started with. Unfortunately, we too often see this scenario where we end up with the acute trust full, backing up into the community hospitals, and the whole system sort of grinds to a halt. So it became very clear earlier on that we need to do something to change this. So we came up with 5 key principles really to try and improve things. So robust alternatives, which we're talking about today, risk stratification, improved end-of-life care, so obviously improve that at home. Try and get smooth flow through that system, so if people do get into hospital, they come back out quickly, so you don't black up. And looking at specialist rehab. So the main one we're talking about today is the risk stratification and case management. And how those 5 things fit together in the pinball is basically just beefing it up, more levers. So there's more there and more at the top there working in a coordinated way. And we talk about whole system, that's kind of the whole system. Even that's not complete. We've got other bits on there that just we haven't included, such as the hospice and things like that there's just not space really. These slides I think are available afterwards, so I will whiz quite quickly if that's okay, just because of the time, but they are there to have a look at afterwards. So that's the urgent care, that's the whole system. So move from there. Right, basis, complex care teams. Back in 2008, with some Department of Health funding, our community teams were restructured. And the idea being that we went from having all our community teams, like district nurses, physios, etc., all seemed to be overlapping different areas, different practices. And the idea of the complex care teams was to bring them all together on a geographical basis. So they're linked around 3 or 4 practices, or up to 5 in some cases, and all the team cover just that set of cohort of patients. So they start working together as an integrated team. And that was back in 2008. It's a bit of a varied geography because of the size of Devon, we have a few providers, and that obviously changed a bit with transforming community services as well, so it got a bit more complicated. But essentially also part in North Devon, our community services were already a integrated service, so they were health and social care, and they were also vertically integrated into the acute trust back then, 2008, with its pluses and its minuses that come with that. So we got our complex care teams, they were reorganised. So we had the teams there covering a certain area. So you think that's part of the business, and that's basically the complex care team there as a sort of graphic there. And when we do it, we do talk about also involving our community hospitals and the practices, voluntary sector, etc., all of there. And we're looking to bring in the care of the elderly consultants and cluster pharmacists into that as well. So you're getting a real broad, proper integrated care, multidisciplinary team across multi-providers. So that's the structure. The Nuffield Trust were therefore commissioned to see whether the POPs project's a success, this investment they put into reorganising, did it work? And again, just the main thing to look at is that one phrase really, which said they went to look at the teams, and actually when they matched them against the population elsewhere, they found there was limited impact by having everybody in the same place. And when they ran it against one of the predictive models, they found that the people they did have an impact on were the ones who were deemed at high risk on a predictive model that the Nuffield Trust were using at the time, the PAR++ and CPM. So the outcome of that was you can have the teams in the right place, but you need a bit more. And that's where we came to the idea of the virtual ward, which essentially, I think I heard some Garen Lewis speak, who was developed them in Croydon many years ago, back in 2006, 2007. And the concept is a simple equation. You use the predictive modelling and this multidisciplinary idea of case management. You add the two together, and you're targeting all your skills and your facilities there at the most appropriate individuals. And it's that sort of looking for that most greater impact. And that's the simple equation that sits with it. So where do we start? So you need a predictive model. Many of you may have heard of PAR and PAR++, which were originally developed by the Nuffield and the King's Fund and the Department of Health many years ago. Our first PAR list came through in the top 3 by the time we got it, had unfortunately already passed away. It was a huge delay in there. It was based mainly on the hospital data. So they went to start using how can you use more rich data, so using the information that's held in the practice records. And that's where they developed the combined predictive models. So you started adding in primary care data and trying to improve the predictability of it. They made that freely available, the Department of Health, to anybody who wanted to have a go at running it locally. So NHS Devon, within the commissioning information team, managed to get the skills to develop it in-house. And we started running with the CPM back in 2008. We then further evoked and tweaked it to local calibration to make it the Devon predictive model back in 2010, and that increased its accuracy up completely. And we started adding in other data sets like ambulance data, out of hours data, all these other things to improve the predictability of it. One interesting fact, registration duration. So people who've been in with a GP for a short period of time, a new GP, had a higher risk of admission than those who've been there for a period of time. And that again sort of generates the idea of communications and integration and working through. So, and that's just an idea of the improvement by locally calibrating our model. So just the top rank there, you can look, the combined predictive model had a 71% positive predictive value, and by calibrating it locally, you went up to 86%. So you can just see the predictive accuracy of the model. And that's important to remember, that's been tested on our real population, so they're real numbers, they're not theoretical, that is actually how accurate they are. So you can have some sort of basis of trust in what you're seeing in the numbers. So we run that monthly. And then we have the virtual ward, which essentially is basically using that predictive model, the team I described earlier, and trying to bring that together and targeting that intervention at those people that are most appropriate. So we run it monthly. The practices are encouraged to meet monthly with the complex care team, and you assign a certain number of people to admit to a virtual ward. The idea of having a virtual ward is you've got a limited number of beds and you're targeted, so one in, one out. If you identify the people you needed to see, you identify what their needs are, you provide that intervention in a multidisciplinary way, all the whole things from environment through to medicine to social to psychological, all those things to prevent the peaks in admissions that we're going to follow. And then when you're ready and you've completed those tasks, you discharge and bring somebody in and you keep that turnover going. And that's essentially how it works. And we're now plugging in more of the exacerbation pathways into that, so the communication to the COPD teams, etc., is all in there as well. So that's that. How do we get it going and running? Essentially, the virtual ward sits there at the moment between primary care and what are called community services, but as I said, that's actually much broader than what you see. That includes social care, community services, so partnership trust for our elderly care psychiatry. It goes on really. So it's trying to bring it there. So we're promoting integrated whole system care using the virtual ward as a bit of glue in there. And how do we ensure it happened? Well, as I was at the Nuffield Trust a couple of weeks ago, and practically every team that presented had some sort of financial incentive in there in some form. We got ours driving to start with a LES at the beginning, a sequin LES for practices, and that encouraged, I'll talk about it in a moment, practices to sign up. And to give you an idea, we went from 12 practices allowing access to their records for the CPM up to 104 in a matter of 3 months. So it gives you an idea of the power of financial incentives. And we're now adding it into the other side of the equation, looking at how we can improve the responsiveness of the team to newly identified patients by using the sequin LES on the community side of their sequin LES. And obviously the specifications for the services as we're rewriting them is becoming more and more strongly worded on how they interact in the whole process. So it's important to understand the LES basically so you get an idea of timescales if you're going to do this on how quickly you can roll it out. Well, essentially we've seen this level of evolution. So the first year back in 2010 was really quite basic. We paid practices to sign up and allow access to the data. It seems to overcome all sort of governance issues, I don't know why. Identify patients they'd like to be in agreement with the team on how to case manage them, and then produce an out-of-hours message for our out-of-hours service on Adastra, so there's a way of linking up with the out-of-hours service. Second year, we decided to narrow it down and start ensuring that we are targeting this top group. So we put restrictions in on how many people should be admitted to the virtual ward based on the predictive model and how much flexibility there were in there from the triangle. And again, we just used that as one of the caveats for payment. Basically, our results. So the NHS Devon has changed quite considerably since the 4 years. You imagine that probably everywhere is the same, that over time things have changed. So originally, when we started the rollout across the whole of Devon from the 3 pilot practices up to the 103 practices, we were one organisation with one provider. And we ended up with 2 providers, 3 providers of community services, and we're split into 3 localities. And since then, we've now obviously become a CCG with a different locality swap going on. So it's all very confusing. But essentially, the 3 localities then were able to have some sort of autonomy in how they managed it, and there's some differences in how the 3 approached it, and the main ones to point out is that they all had access to the DPM or the practices, they all had complex care teams, 2 of them had full-year leses, 1 didn't, so you lose the financial incentive there. They decided to try and focus on another area. Only 1 of them put in full-time project support to go around to these teams and these virtual awards and support and educate and facilitate, break down some of the barriers, get the joint working going, which is just there really between primary care and community. Different providers. Investment, the les was pretty much the same if they used it, so the investment was there. And fair share as well, historically across Devon there's been some difference in funding for community services, so you can see there's a bit of difference there. I'll put those on there because there was different results and you can try and get an understanding of what's important and why the results happened. So there's the evaluation really. We're 2 years in. And locality A, which is the one that did everything, so the project support, basically when we look at what's happened in this top highest risk proportion, 0.5%, they've dropped emissions from that group by 22%, which when you equate that to PBR costs, and we've looked at the equivalents, is getting on for £1 million, especially when you consider there would have been growth, which is essentially what we saw in locality C, which, as I said, didn't use the layers, didn't have the project management, just left the sum of the parts to do their job. And I think there's a lesson learned there. If you're going to do something like this, you need to have the project in there and the support and pushing it the whole time to encourage. And in the middle ground was the hedging the bets, which is our locality up in the north, which has seen some improvement. There's still a 14% drop in that top risk, but we labelled as could do better on our report, which is where we're aiming for now and taking on that learning. The important thing is the locality C. If even with the sum of the parts, there would have been growth that year. So you add those 2 on, and you see how impressive locality A did by going for it full kilter. And the important thing to say is we obviously, one of the risk scores, part of the component of the risk score is their previous admissions. So if you start reducing emissions, you start to see an effect on the population. It's almost like a feedback loop that goes on. And we're starting to see, as we always think of the Kaiser pyramid, that when you start actually reducing, getting control of that really expensive top difficult group with their apparent emissions, you start things narrowing down into more of a point. And we're starting to see that feedback now. It's important because one of the things that originally we were looking at putting the funding community teams based on their profile. Well, you've got to make sure they're not already doing something well, because the profile does change. So it's just important learning, and we're looking at keeping an eye on that. And finally, stage 3, so that's where we're at now. And essentially it's trying to ensure we get this communication going on a routine basis between all the teams, lead GPs within the practice to get ownership, get the enthusiasm going, and as I said, trying to improve the time from identification to actually the impact. One of the other learning points is we talk about proactive case management. It always gives this almost relaxed view that you can get to them at some point, where actually you actually got quite a short windows of a couple of months, a few months. So to get in, you do actually need to be quite a responsive, proactive service, ironically. So it's really to get in there quite early, and that's one thing we're leading on and pushing on. And the last slide is it's got upstream targeting, so become truly proactive as it were, almost a popcorn effect, so trying to identify who's going to pop next, the things that are changing, because we're probably picking people at between point A and point B at the moment, just because this delays in everyone meeting, and we have taken the top off, as we've seen, and the regression down we've made come quicker, but the quicker you can get, the earlier you can get up, the impact will be even greater, so that's where we're pushing towards now. That's it.
Paul, while people are thinking of what question they might ask you, can I ask you one quickly? You've reduced the payment by results tariff. Has that reduced the number of beds in North Devon Hospital?
Oh, that's so loaded. We're in a rather difficult place in North Devon, and obviously our trusts are very, how do I put it, are struggling with their FT application at the moment and making numbers match. To remove costs, obviously you've got to think about closing beds, but where those beds are and how that's done is a whole other discussion, especially when income is quite important to a trust that may not make their FT application. So you're paying on tariff, so ironically, we're moving to a block next year to support the trust. So it's less important just for the year, just we have to do that to support the trust. But yes, in theory, the principle is, isn't it, unless you close beds, you actually release the saving out. But certainly from a commissioner point of view, we've paid less on tariff for that.
Well, that's great, and presumably that's the next stage. But what concerns me nationwide is people are reducing referrals, doing this wonderful pioneering work that you've done, reducing the tariff, but somehow the overall hospital bills remains the same.
Yeah, it's quite interesting. Zero length of stays that ours have gone through the roof, but not in this group, which is quite interesting. So it's constant playing the game, isn't it, of trying to identify where the holes are in the system and trying to plug them.
Well,